Good morning, everybody. We are so thrilled to have you here joining us to talk about the way forward for the sick and small newborn. Thinking about innovation, thinking about models of care, and the perspective from a diverse set of donors. We're really excited that there's so much work going on in this space that has, with these newly released statements from the World Health Organization, forthcoming guidelines on the care of the preterm infant on November 17th, policy shifts, research studies, and implementation projects. And a colleague just mentioned that the effective coverage session that's running in parallel to this seems to have some really significant overlaps about measurement and what has been connected with sick and small newborn care overall. So I hope that we are going to be able to touch on each of these areas around policy, research, implementation, guidelines. And our hope is that this is a really interactive process. So we're going to have some speakers present their perspective, and I'll introduce everybody in just a minute. And I do want to note that we have 3 of our panelists who are presenting in a hybrid format, partially due to visa challenges, but we're really excited to have our colleagues from Kenya and Malawi join us remotely. So if you're on Zoom and you're connected into the online session, we really hope you'll use the Q&A chat to be able to share with us what you're thinking about, how we can engage in the conversation with you to keep this as a fluid conversation. So I'm honored today. That is not going to work. 1 second. There we go, thank you. I'm honored to moderate this panel today with my colleagues, and so let me take a minute to introduce them and who they are and where the perspectives that they are presenting. But first I should introduce myself. I'm Dr. Catherine Semra. I'm a maternal and newborn health epidemiologist and the director of the BetterBirth program at Ariadne Labs. Now, Ariadne Labs is a joint health innovation center that sits between Brigham and Women's Hospital and Harvard T.H. Chan School of Public Health. And our team really focuses on co-designing interventions that support and improve maternal and newborn health overall. I'm joined by my colleague, Dr. Tisungane Mbalo, called Tisu. He's a pediatrician researcher and the co-principal investigator on the low birth weight infant feeding exploration study. And I've been honored to partner with him as the PI on that project. It's affectionately called the LIFE study, and you'll be hearing some of those results today that he will share with us. Next, we have the Honorable Dr. Charles Mwansambo, the Principal Secretary of Health at the Ministry of Health in Malawi, and a pediatrician himself. He's going to share his perspective on policy and focus on newborn care. And finally, we have Dr. Gagan Gupta, Senior Advisor and Team Lead for Maternal Newborn Health at the UNICEF headquarters. He's also a neonatologist and will share his perspective from the global policy perspective, the guideline development process, and what he sees as the way forward to make change. And finally, we have Dr. David Gathara, Assistant Professor of Health Systems and the NEST 360 Health Systems Lead at the London School of Hygiene and Tropical Medicine. He's also a nurse, and he's going to share his perspective from implementing newborn care through engineering, innovation, and quality improvement. So what brings us all together in this room around the sick and small newborn care? As many of you know, more than 20 million infants are born with low birth weight, or weight under 2.5 kilograms every year. And we know that more than 60% of all neonatal deaths occur in this population. So not only are these infants at higher risk of mortality, if they survive, they have poor growth and poor neurodevelopment outcomes. And our team has particularly been focused on the moderately low birth weight infant, those children who are 1.5 to just under 2.5 kilograms, because we think they offer some of the greatest opportunity to help us reduce mortality, improve outcomes, and help the world meet the Sustainable Development Goal around newborn mortality. Now, much of the global effort so far has been really focused on preventing poor outcomes using clinical or medical interventions. And even in 2022, we actually have very limited evidence to support our infant feeding strategies and thinking about growth, particularly for this moderately low birth weight population. The most current infant feeding guidelines are actually from 2011. Most of them are based on predominantly low or very low quality evidence. And further, most of the data is actually from the very preterm, extremely preterm, or extremely low birth weight infants, predominantly in high income settings. So we clearly have need for a lot more information and understanding about how we can improve their care. Currently, and as you'll hear today, there's some excellent quality improvement methods that we need to scale up for the NICU and small newborn care units. And finally, this HSR community, the reason we're here with you all today, we know that it requires a health system to create these changes and health system level interventions to create positive impact for care and outcomes on the sick and small newborn and their families. We're at a time of great momentum, though, around the sick and small newborn. Despite the gaps that I just shared with you, there have been a number of opportunities that have been highlighted. In 2017, there was a call to action by 40 global health organizations that issued a call to really focus on the current state of feeding for the sick and vulnerable newborn. In the past 2 years, the World Health Organization, UNICEF, and USAID have all released reports and guidelines focusing on the care of these vulnerable infants. And furthermore, the Every Newborn Action Plan has focused on a target around improving coverage of the sick and small newborn care unit, namely that 80% of countries have a national implementation plan that is being implemented at least half the country with an appropriate number of functional level 2 inpatient units. So with this interest and investment galvanized, the research is needed to develop evidence-based approaches to translate these findings into action and ensure that we have the right care for the most vulnerable infant. So the question to us is, what does it take to scale up the care so that these children do not only survive, but thrive? I'm thrilled to ask Dr. Gagan Gupta to share his perspective about what it means to scale up the care. And we'll switch the presentations just now.
Thanks, Catherine, for the nice intro and setting the tone so well. And thanks to you, Linda, and the Ariadne Labs team for preparing so hard for this session. Really appreciate that. Greetings to all of you. I'm Gagan from UNICEF headquarters. And over the next 15 minutes, I will try to take you through what it takes to scale up the facility-based newborn care in different contexts. I would be building up on where Catherine left about why, and moving from why to what and how. And I would also take a lot of examples from India, which has been pioneer here, and we have Dr. Rajni Vaid from National Health System Resource Center. She was previously the director there. And many other countries like Bangladesh, Sierra Leone, Malawi. We have Dr. Charles from Malawi online. How they have been able to overcome these barriers and take the things to scale. Now, let me begin with the story of India. The story of India, not many years before, many believed could be written in a low-income group country. But it's a story from moving from a pilot to a national scale-up with strong government leadership, very committed funding, and strong collaboration with the partners. And starting from a pilot to virtually breaking the glass ceiling with 1 million newborns admitted now each year in these units. Now, as it says, it's a journey. And when you are on a journey, you need to plan it well, and you need to know where you need to go. So even if you start small, think big. You need to know where you need to be after 10 years, and put all those pieces one by one as the milestones in the journey. Now the narrative for the deliveries is shifting globally, from home and huts to the hospitals. If you see in last 2 decades, 55% increase has happened in the institutional delivery. So have the referrals increased from community-based programs like IMCI and the home-based newborn care. But referrals to where? to a functioning facility or a non-functioning facility. Mothers delivering where? In the four walls of a hospital, or something which is well equipped to save the small and sick newborn. And that's the issue which many countries are still grappling with. Now, when India started, one of the good things they did was they defined the levels of care very well. Essential newborn care in all labor rooms, across all delivery points. At the sub-district level, which is a population of nearly 100,000, a kind of a stabilization unit. And then at district level, which is nearly 1 to 1.5 million, a level 2 small and sick newborn care unit, and ensuring the kangaroo mother and father care is well integrated with these units. Now, what are the 5 key lessons which we can learn from India's scale-up? And these are all around health systems. The first and foremost is defining the levels of care and ensuring the necessary funding for the program. And not only the funding was ensured, the district budgets captured these lines very meticulously. The second is a lot of investment went in the infrastructure upgradation. Because when you have to create these big newborn care units, you also need to upgrade your infrastructure. And not only it was upgraded, it was also standardized so that it becomes easier for districts to understand what is expected to bring these services into action. The third is putting in place a system of equipment procurement, and not only procurement, but maintenance, because it's easy to procure equipments, but more difficult to maintain. And I would be coming on this point further. The HR norms and policies to attract the human resources and the capacity building of it. India did many innovations like you quote, we pay. In difficult areas, people were asked to quote the pay packages they want, and they were given. The difficult area allowances, decentralizing recruitments, walk-in interviews. So many of those HR policies which were changed were also very helpful. And last but not the least, to know what's happening in these units, using a real-time monitoring and a strong follow-up system. Most importantly, working simultaneously on all these and not sequentially. Often we are guilty of buying the equipments and then thinking of creating the human resources and the infrastructure. So you need to work on all these things simultaneously and not sequentially. And what did this lead to? From a multi-partner supported pilot in multi-states between 2008 to 10 to the national scale-up by 2019, with nearly 1 million newborns being admitted consistently every year, and more than $500 million invested by Government of India in its scale-up. Now, let me go to the second part of my presentation. What all these learnings from India, Bangladesh, Sierra Leone, and Malawi mean for the other countries, and how do we move ahead with a 10-step model for scale-up? The first and foremost thing is you need a long-term vision. Any country which is embarking on the journey of scaling up newborn care, especially the inpatient newborn care, they need to know where they want to be in 2030 and 2025 as first milestone for it. It's important for government to lead the whole process. Partners may fund it, but if the government leadership is not there, you will find scattered islands of excellence and pilots, but nothing which will be systematically scaled up. It's good to set up a national technical group for the facility-based newborn care, which includes also the representation from the states. Because if the states and provinces are engaged from the beginning, the buy-in will be much higher. And also don't only restrict to pediatricians and neonatologists. Bring the nurses in, bring the biomedical engineers in, bring your HR people in, bring the data people in. If they are all the part of the thinking process, you will be able to think more holistically. The second thing is once you have a vision, put in place a national plan. And this is the Bangladesh National Plan, which clearly defines how the scale-up will happen. While planning, define the levels of care, and do not forget the essential newborn care, because that is the foundational stone for the basic development of the level 2 newborn care. Also plan for a multi-district pilot, because if you start in one district and you get headwinds in that district, your program will not run ahead. But when you are doing it in multiple districts, it helps you in two ways. One is it increases the competition between districts and the states. And number two, in case you fail in one district, you still have a reasonable chance to succeed in the other districts. So once you have the national plan, and once you have put a few pilots, it's always good to engage the political buy-in. Because this is a very visible intervention. And politicians do like to engage with visible interventions which are associated with the masses. This is an example from Sierra Leone, where the president of Sierra Leone visited the unit, and after that there was a distinct momentum. You can leverage a lot of financing by that. You can leverage a lot of human resource policy changes by that. So having the political buy-in, because seeing is believing, and once they go to these units, the intensity of scale-up definitely gets a boost. Now, once you have all this, you have a plan, you have a buy-in, you need to fund and finance it well. Now, in different contexts, it may work differently. In India, the money came entirely from Government of India, the National Health Mission. But in Bangladesh, part of the money came from government, part of the money came from partners. In Sierra Leone, 80% money came from partners, but 20% came from government. But wherever is the funding coming from, what is important is to have an exit strategy, that after 5 years, how the country is going to sustain the whole thing. And budget is basically an interplay of two things. The establishment cost, which is a one-time cost, but the major cost is the running cost for the human resources, for the consumables, and it's important to factor that in from the very beginning. And it's also good to standardize the costing of different things, and these are the examples from Bangladesh and Sierra Leone, where they have standardized the equipments, the quantity of the equipments, and the costing of the equipments. And this helps in having a clear budget line in the national plans. Now, the fifth important step is the infrastructure planning and standardizing infrastructure. You may go for a new construction, or you can renovate an existing space. But what is more important is sit with your technical group and see what kind of services you want to provide for level 2 newborn care, including the linkages with the labor room, including the support for the feeding, including the support for the follow-up. Once you have agreed on what services you are requiring, you can standardize them into different kinds of floor plans. Some of them can be rectangular, some of them can be oval, depending on what kind of spaces are available. And then these can be rolled out in the districts based on the availability of the space. The next step is the equipment procurement and maintenance. And as I said, equipment procurement is the easiest thing to do. But ensuring they are operationalized and ensuring that they function well and repaired in time is the most difficult thing. And we have some good examples from Malawi. We have some good examples from Sierra Leone. We have some good examples now from Ethiopia around the work which is going for the equipment, the biomedical engineers and technicians. Initial procurement often is supported by partners, but it is better earlier the capacity, the domestic capacity for procuring equipments and doing tenders is initiated. And also build the local capacity. You can train the cold chain technicians to maintain the warm chain. It's important to have someone who knows how to fix the basics. And most of the small breakdowns can be repaired at district level, and they do not require a very high level of intervention. The next and the most critical thing is the human resources. And attracting and retaining human resource is a huge challenge. But the fact is there's no getting away from it. And the first step is never ever assume that human resources are not there. First thing we need to do is we need to put and standardize what should be the human resources for a newborn care unit. You need 12 nurses, you need 15 nurses, you need 4 pediatricians, 4 medical officers, whatever, set the norms for the country and create those positions and budget for them. And then see how will you get them. There are examples which I showed from India, decentralizing recruitments, allowing walk-in interviews, looking at differential pay packages, giving intensive care allowances. There have been many strategies. There is no one size that will fit all, and there is no quick fix solution to it. You will need to put multi-pronged approach, including the service bond for the fresh postgraduate candidates. So there are multiple options which you can look at, but never ever assume that doctors and nurses are not available. And the political and bureaucratic commitment is very critical for this. The 8th important thing is we need to know what's happening in these units and what happens to these newborns when they go back home in the community. And that's why you need to have a strong data monitoring system. The first step for is you standardize what you are recording in each unit. When we started, different units were recording different variables. So first thing is every unit needs to standardize what they are recording. You can start with a paper-based system, but earlier you shift to a digital online system. It helps because it will give you analyzed data at the tip of your finger. So lastly, you need to analyze that data and give a clear feedback loop to the districts for corrective action. And I will give you 2 examples from India and Bangladesh. So this is the paper-based system. You can see the admission sheet. It has been pretty much standardized, and so is the discharge sheet. And then the Indian government made a provision of a data entry operator in these newborn care units who would digitalize the data, and then UNICEF helped in developing an online software which will give you the analyzed graphs immediately, and you can see it sitting from anywhere in the world. Same was with Bangladesh. You can see very standardized neonatal record sheets. All units are recording the same variables. And this applies for labor room, this applies for pediatric ward, any inpatient care. You need to standardize what you are recording. And once you have standardized, you need some system by which this can be entered and analyzed, and these graphs can then be used for the review processes. Coming to the most important thing which we forget. Parents are not the visitors to the newborn care unit. They are part of the care. And engaging family in the care from beginning is very important. Policies should encourage family and mother's engagement in care and zero separation, because ultimately it's the mother who has to handle the baby when they go back home. Ensuring free food for the mother, toilets and the place for shower and mother to stay should be a part of the plan. If you don't get things within the unit, try to get it as close to the unit as possible depending on the available space. And you can see some examples from Vietnam, where even on CPAP, the baby is with mother. From Sierra Leone, mothers being the part of the care in the newborn care unit. And last but not the least, ensure a system for post-discharge follow-up. Once they go back home, there is a very high risk of them with developmental delays, a risk of not thriving to the full potential. And data from many countries say that when these babies are discharged, large number of them are still below 2,000 grams and need continued investment for survival, growth, and development. You can start by your existing community follow-up system. You have a community worker in the country. They are doing home visits for the normal babies. This can be expanded further to the small and sick babies with a strong referral arm. And lastly, once you have this follow-up system, integrate the developmental assessment, early intervention, and the ECD thing in the whole follow-up. So as I conclude, I leave you with these 10 points which I said. And these 10 points are the 10 steps for the generic model for scale-up at district level, which UNICEF and WHO had proposed earlier in the year. This was based on the country consultations with more than 500 participants. And these are the 10 steps from vision, financing, human resource, infrastructure, equipments, data systems, referral, linkages with maternal care, family involvement, and the post-discharge follow-up. And most importantly, work simultaneously on these 10 steps and not sequentially. And as I conclude, I leave you with the slide, let's live this dream together. And many of you have been contributing in your countries as leaders, as public health practitioners. Let's take it to scale. Thank you so much.
Actually dive into the recordings from our colleagues in Malawi and Kenya, I just want to open it for the floor. Any reflections on what Dr. Gupta shared? These 10 steps seem very clear and straightforward, but the implementation is always challenging. So just wanted to open it up for a minute and see if there was a reflection or a thought from anybody. Yes. And then I'll come back to you at the back.
Hello?
Okay.
Hi, I'm Kate Ramsey from Scope Impact. Thanks so much, Gagan, for your presentation. I was kind of interested in about the model and setting up the space, and I wondered how those models were designed, whose perspectives were taken into account, and how they take into account also what you mentioned about families being an essential part of the care.
I'm going to actually take 2 questions, and then we'll answer and then come back. So at the very back table, please. And Gagan, I'll come back to you. Is that okay?
Thank you. Arlette Moman from Mozambique National Institute of Health. Thank you for the presentation. I was wondering, in these steps, did they take into account health facilities in rural areas like Mozambique, where we have like a very small maternity ward and there's no place for kangaroo? And during this implementation process, what was the experience for those health facilities that did not have kangaroo for those mothers? how are they teaching them to do the process of kangaroo? It's a very ambitious plan, but it's always important to think more than that, like in a very rural area where we don't have any resources to implement this kind of intervention. Thank you.
Great. Can I have you answer?
Thanks so much. So for the kids' question on whose perspective was taken while designing, so there was an expert group which included neonatologists, which included even the nurses from the districts, and it included the development partners. One thing which was probably missing was the families and their engagement in the care. And as I said, you learn when you do. So we started with SNCU, there was no follow-up system. The follow-up system was integrated later. There was no data system to begin with. Then we realized what's happening to these babies. The family-centered care was not a part in the beginning. So as you progress, you evolve. But what's important is you identify the services which are required in a newborn care unit, starting from triage to the inborn versus outborn versus breastfeeding area versus the follow-up OPD, place for kangaroo care. So once you identify these space, then you try to see within the available space, what can be made available and what extension of the space is required. Now, in regards to Mozambique, I had the privilege of going to Mozambique and spend a week in 2020 there and visiting all the places to support the thinking around small and sick newborn care. So one of the things is when you have these peripheral centers, it's important that you have more of a stabilization unit where you can stabilize the baby. You can, if the baby is stable, it can be continued in kangaroo mother care. But if the baby is not stable, a strong transport system is very helpful to take the baby in time to a district level facility. So the peripheral network needs to rely more on stabilization, but with a good transport system to a district level facility where these can be operationalized. Thank you.
Excellent. So I'm going to take one more that was here, and Dr. Ved, and then I'm going to turn us back to the videos, and we'll answer some more questions in an additional Q&A process.
Thank you. Hello, I'm Marine Vignon from Alima, Senegal. I have a question about the pilot project. From the pilot project to the scaling up, what was the most challenging on the 10 step, in the 10 step? The other question is about the community communication and awareness. Is it a part of the scaling up also?
Right. So the most difficult thing from pilot to scale up was probably the human resources. Getting the human resources was the most difficult thing. But as I said, we started by having the norms, and once we had the norms, we budgeted for them, and then the HR policy was changed. And there is no single fix for HR. You need to do multiple things, and everything will have an incremental effect. In terms of the linkages with community, that came pretty late, because one thing which we realized was that we are missing the linkages with the community, and both in terms of what happens when they go back into community, and also in terms of having a demand generation in the community. But later on, when we engaged with the community health workers, and when they were aware that these newborn care units are functional, the referrals became much more from the community, and around 15% babies who are coming to the newborn care units are coming through community referrals, and around 20-25% are from the outbound, from the other health facilities.
And one more, Dr. Ved, please.
Thanks, Dr. Gagan, an excellent presentation. I have one question about human resources. You sort of made it very explicit, 4 pediatricians, 4 medical officers, X number of nurses. I think it's time for us to start speaking about task sharing and task shifting. Because, I mean, even though we might assume that they're not available, the reality is that there's a huge shortage of specialists, particularly in remote and rural areas. So I think it's time for a conversation on task sharing, task shifting, legal scope of practice, and that needs to actually begin now. Else we'll always be searching for this elusive pediatrician who's not going to be available.
I fully agree, Dr. Rajni, with this, and that's why we are now in the process of setting the norms, but like there was an initial push for having a neonatologist level on a pediatrician. And we said that you can easily manage these units with 1 pediatrician and 3 medical officers who have been trained in that. And as you recollect, in India, a lot of medical officers were trained into the level 2 small and sick newborn, and they were put under the umbrella of 1 pediatrician. So task shifting definitely. And Sierra Leone, when I was there, I saw a lot of nursing aides and nursing volunteers helping with the staff nurses. So we need to find mechanisms which can be, and also engaging families in the care. That will also relieve a lot of burden from the nurses as well. So.
Excellent. So I'm going to turn us over to Dr. David Gathara, who's actually going to share some of this idea around implementation. How do you take these 10 steps and implement using the experience from the Nest 360 work to improve NICU and SNCU work from a nursing and a research perspective. So I'm going to turn to Dr. Gathara now. We have a recording of him, but our panelists are on live for the Q&A session as well at the end. So can I have Dr. Gathara's video?
Off with a video on a baby called Chico Gesto, a one-day-old baby. Thank you, Gagan and Catherine, for setting such a great background to this talk. I'm Dr. David Gathara. I'll be sharing research and program implementation for small and sick newborn care within LMIC health systems using experiences from Nest and broader work in Kenya. I will start off with a video on a baby called Chico Gesto, a one-day-old baby, a good representation of a lot of what we see in our newborn units, baby with respiratory distress, and
We're just making sure our colleagues on Zoom can see the video, so apologies, just 1 second.
Thank you, Gagan and Catherine, for setting such a great background to this talk. I'm Dr. David Gathara. I'll be sharing research and program implementation for small and sick newborn care within LMIC health systems using experiences from Nest and broader work in Kenya. I will start off with a video on a baby called Chico Gesto, a one-day-old baby, a good representation of a lot of what we see in our newborn units, baby with respiratory distress, and tube requiring support for feeding, IV fluids, potentially on antibiotics for management of infections. And what we realize is that the one-at-a-time interventions will not work to save this baby. We need technologies that are sustainable and beyond the one-at-a-time that come with maintenance systems, local biomedical engineers being able to look at whether this device but also have availability of spare parts. We also need to think about, health systems transformation and leadership. That think about health workers and especially skilled nurses in sufficient quantities, and skill makes availability of space and basic infrastructure, including wash, data systems to measure and drive change and measure long-term outcomes to ensure USC financial protection, but also focusing care that is family-centered care that prioritize to do no harm first, but also thinking about follow-up systems to ensure that when we discharge babies, that we don't have mortality in the community. So the Sustainable Development Goal 3.2 focuses on ending preventable newborn deaths, with all countries aiming to reduce neonatal mortality to at least 12 per 1,000 live births. Enough coverage target 4, 80% of these are at least one level 2 inpatient units to care for small and sick newborns with respiratory support, including CPAP, and that's a focus of pretty much of where the Nest 360 implementation work focuses on. And the level 2 special newborn care interventions span thermal care, assisted feeding, and IV fluids and hydration, respiratory distress detection and management of sepsis, jaundice, and encephalopathy. A quick background about Nest. Is an alliance of 16 organizations working with governments, 11 of them in Africa. We support African governments to implement a package of care that includes affordable technologies, training for clinicians and biomedical technicians, and locally owned data to deliver high quality small and sick newborn care. Mainly and working in 4 countries, Kenya, Malawi, Tanzania, and Nigeria, 67 hospitals across these countries with over 5,000 deliveries per year, 80,000 admissions per year. And the focus of the work is to catalyze country-led change using these broad themes on delivering and sustaining innovation, develop an education ecosystem, and implement evidence-based care. And with regards to developing and sustaining innovation, we test and qualify newborn health technologies for low resource settings, and jointly work with UNICEF to develop target product profiles for medical devices for newborns within these settings, promote innovation by building an ecosystem of innovators to develop newborn health technologies where no sustainable devices exist. And we have innovation labs in some of our countries, and distribute and maintain a bundle of newborn devices, including through Hatch technologies. And the bundle of technologies span breathing support, prevention and treatment of infections, hydration support, monitoring and treatment of jaundice, temperature stability, and point of care diagnostics. We partnered to deliver clinical and biomedical engineering training through competency-based service and in-service training, so that devices are used and maintained. But these trainings also align with clinical guidelines and recommendations from WHO and other local and other major organizations, providing clinical guidance, empower clinical and biomedical teachers to teach effectively with general instructors course, and strengthen innovation education across Africa by fostering local innovation capacity. And as part of this work is developing generic education materials that span, maintenance and troubleshooting of medical devices. Be adopted into context, but also videos that actually walk people through how to maintain or troubleshoot a device, but also videos on how to set up a baby on, for instance, CPAP. Working to integrate quality improvement tools, pretty much reflecting on, for us to know what change and progress we are making, we need to measure what we are implementing and use evidence-based care for action. Evidence-based care using data for action, integrate quality improvement tools and processes to identify and act.
Given the technical difficulties, I'm going to have us transition to Dr. Tisu Mbalo. And David, if you're on the line, I will come back to you and have you highlight the points during the Q&A to present, because it appears your slides haven't made it through on the recording. So I apologize for the technical challenges we're having. Can you switch it to the next presentation, please? So next is actually Dr. Tisu Mbalo from Malawi. As I mentioned, he's the pediatrician researcher. No, the next recording, please. Dr. Tisu was the co-principal investigator on the LIFE study, the Low Birth Weight Infant Feeding Exploration Study, which was funded by the Bill and Melinda Gates Foundation. We're grateful for that support.
Good afternoon or good evening, depending on which part of the world.
And hopefully his slides will come through on the recording as we checked.
So I'll be presenting research on feeding and growth in small infants in relation to the LIFE study, the Low Birth Weight Infant Feeding Exploration trial that we conducted. So, as a background to this study, this was actually a study whose main or broad aim was to understand the feeding practices, growth patterns, and child development and other health outcomes among moderated low birth weight infants. These are those of the weight between birth weight of 1.5 and 2.59 kg in resource-limited settings throughout the first year of life, with the broad aims of identifying potential interventions, target group or high-risk groups, and informing research agenda and enhancing global guidelines on how this vulnerable population can have an improved health outcome. This was a mixed method study that was conducted in 3 countries, that is Malawi, Tanzania, and India, with a variation of amongst the 12 hospitals involved. These 12 hospitals were either secondary or tertiary hospitals, and there was also a mixture of public and private hospitals. So we had a couple of data collection streams from which we collected data from August 2019 to July 2021. And these 6 streams were firstly a facilities needs assessment, which was basically an assessment on looking at each hospital, what's the capacity of each hospital, what are the staffing levels, what is the equipment that is available, what types of feeding aids or feeding supplements, if any, are available for these vulnerable babies. We also conducted a retrospective chart review, reviewing the documentation of the care of these low birth weight babies, and this was actually conducted prior to prospective or other, other arms of the study, so that we could avoid the Hawthorne effect, or rather different behavior that people would do on how they would work on a daily basis if they know that they're being observed. We also had a qualitative component whereby we had 213 stakeholders involved in 37 focus group discussions, as well as 132 stakeholders directly involved in in-depth interviews. We also had an infant seed observation cohort, whereby in this cohort we actually would observe mother-infant pairs, low birth and mother-infant pairs from birth up to discharge at predetermined frequencies, and also at predetermined standardized tools. The largest cohort from which our data was collected was a prospective cohort of mother-infant pairs, for which we followed them up for 12 months, from birth up to 12 months. And this consisted of 1,114 mother-infant pairs of low birth weight babies. Now, looking at our cohort, the low birth weight babies, infant characteristics, as an individual group, the yellow bar that we see here with labeled pooled, as an individual group, we actually had the greatest cohort of the type of low birth weight being those who were term but small for gestational age. But there was also a variability of the group or phenotypes of the babies, low birth weight babies across countries, with the Indian sites predominantly having the small for gestational age, that's the same orange that we see, whilst the green and the blue bands were the preterm babies, and these were more predominant in the African countries, that is Tanzania and Malawi. The mean gestational age was 36.6 weeks, and the majority were actually between 2,000 and 2,199 grams. Now, we also looked at how are the infants fed, what is the lactation support and feeding counseling. What we noted was that about 44% of mother-infant pairs reported feeding difficulty. That's a big number, that's a big proportion. We also noted that if you looked at feeding counseling or lactation whilst in support, whilst in the hospital, about 75 to 80% were reported to have at least one session. That might seem like a big number, but that's actually not enough, because we should be targeting all mother-infant pairs of low birth weight babies, and even not low birth babies alone, to have feeding support, counseling support. This number dropped to around 56% if you're talking of multiple sessions. And then you would also note that when they went to the community, it further dropped to around less than 37%. So soon after birth, there wasn't optimal lactation support. If you look at the number of sessions, there was actually less as well as time went by. And this actually continued to decrease as they were stepped down to the community settings in the hospital. And majority of this counseling was only about healthcare providers and lesser by the family members. Now, we also looked at how are the low birth weight babies fed, and we noted that initially the breastfeeding rates are very high. The dark green bars here stand for only breast milk. The light green is mixed feeding. So we noted that when we looked at 6 months, only 44% were exclusively breastfeeding, and there was a big fall, or once we reached 14, 18, 16 weeks in the rates of exclusively breastfeeding. Of concern, we also noted that only 37%, only about a third of infants were initiated on breastfeeding within 1 hour of birth. The WHO actually recommends for optimal feeding to start breastfeeding as soon as possible, that is to start breastfeeding in the first hour of life. We also looked at what are the feeds these babies receive when they are out of that window of exclusive breastfeeding, and the measures are minimum dietary diversity, whereby that is the proportion of babies in this case fed at least 5 of the 8 feed types, and also the minimum meal frequency, those who are fed frequently enough. And these two combined, MDD and MMF, produce the minimum acceptable diet. And we actually noted that overall, 40% of all infants did not achieve minimum acceptable diet at 12 months, highlighting gaps in dietary, the dietary diversity that the babies were fed. And this was actually increased amongst infants born from mothers who were younger, and or those who have socioeconomic challenges such as multifarious mothers, or those who were poorer. We also looked at growth. We noted that as a pooled variate, stunting increased over time, which actually reflects poor nutrition over time. Stunting is actually a measure of chronic malnutrition. However, the measures of those underweight and wasting did not increase as the pattern of stunting was seen. We also looked at how do infants, low birth weight infants, develop. So children are very different because they're also outgrowing or developing people that they're developing. And one of them is the nervous system. How well are they to develop? And what we did is we measured this development by what's called the credit score, the caregiver reported early index of development, or development index. And those who have a Z score of less than 0 reflects that they have developmental challenges. And you would note that most of the babies actually had suboptimal development. And the same was reflected even if you looked at the different types of low birth weight babies, whether they were preterm and small gestation age, preterm, appropriate gestation age, and even those who were term, but small for gestation age as well. We also noted that there were increased, there was an increased frequency or occurrence of poor growth outcomes in some cohort, notably twins and those who are low birth weight and small for gestation age, and those with socioeconomic challenges. Looking at risk factors for growth, we also looked at patterns or signals that we looked at that we could try and analyze. And we found that failure of growth by 2 weeks was a predictor of poor growth outcomes at 6 months. In this case, those who hadn't regained weight at 2 weeks were about 1.5 times increased risk of both stunting and underweight at 6 months. And then we also, this risk of those of poor outcomes also increased as time went by. So if you had poor outcomes at 6 months, the relative risk of stunting, underweight, and wasting was between 3 and around 6.5 as one is continuing to grow. Infants also with poor growth outcomes at 6 months were noted to have also increased risk of developmental delay, as we can see on this, whereby there was increased, there was a difference in on the credit score being lower at 12 months amongst those who were stunted, underweight, or wasted at 6 months. Surprisingly, in the study, we did not find any significant risk, any significant relationship between duration of exclusive breastfeeding and growth outcomes. But we think this is also possibly, there are some reasons why this may be, whether there are different volumes of breastfeeding, whether the different compositions of breastfeeding or what the definition of how it was understood as exclusive breastfeeding was reported. But that is subject to further exploration. But we are not saying that breastfeeding is not important. We're actually saying that we didn't find that as a significant factor relationship in the study for possibly other reasons. So there are a couple of action items that our team is recommended in relation to the live study, and I'll try to go through this fastly because of time. One is it's important to proactively identify and prioritize resources in early infancy to those of highest risk. In our context, it was mostly those who risk factors such as small gestation age might need some more care or some more flagging. Also, we found that the 2-week signal of poor growth was important in the context of development, neurodevelopment, and also future growth outcomes. So we have a signal that might be an opportunity to correct and monitor a bit better. Breast milk still needs some more research in the context of nutrient composition and volume intake in the low birth weight infants, particularly with our signal. Do they need to be fed more frequently? Are there need for supplements? Are there variations in composition in the setting this study was conducted, as well as the need to look into lactational support that we saw that was a decrease in signal as time went by. Thank you very much.
And do a little bit of a discussion to just break up the video monotony and think a little bit about what does this all mean? First, I want to actually go to Dr. David Gathara and ask him to summarize his top 3 points that he wanted to make out of his presentation since we didn't see his slides. So can I ask that Dr. Gathara be able to speak? And please, while we're doing the tech things, feel free to get a coffee, get some food. It is here for you to enjoy. Dr. Gathara, are you able to unmute and speak?
Yes.
Great. The voice
Yes.
from the voice from the sky.
Yes, Catherine.
We can hear you loud and clear. I wonder, David, if you could summarize your top 3 points from your presentation about your experience in Nest 360 and implementation and what that has meant to you.
Yeah, so the main things that are main learning points are, first, we need to appreciate that beyond one at a time interventions are probably not what we need at this stage. We need multiple interventions, and Gagan has provided a very good background on that we need multiple streams of work to implement for newborn care. And within NEST, as part of the research implementation within NEST, is that the main broad themes are we need to identify a way of delivering and sustaining innovation. We still appreciate that there are a lot of areas that require creative or innovative ideas spanning from devices that don't exist within the system, but also approaches to which we implement new interventions. For instance, how do we integrate things within a routine system? How do we improve our infrastructure? Do we upgrade or do we build new newborn units? But to do that, we need also to complement that with developing an education ecosystem that is cognizant of both clinical and biomedical engineers, and foster an ecosystem that allows technical training, but also with generic resources or materials that can be borrowed from different settings and implemented. Train educators or people who will be involved in training of newborn courses on adult learning practices so that they're more efficient in their training practices, but also provide tools and resources for enhancing education. So think about job aids, if it's possible to do videos that can complement the face-to-face teaching when people go back to their units. But more importantly, and as Dagan highlighted, is that we also need to reflect on, as we implement evidence-based care, then we also need to be able to measure what we are doing and track whether we are making progress, reflect and see what changes need to be made. How do we use data for action? How do we set up QI, quality improvement practices, to continually develop and improve the care that we deliver in our newborn units? And just to summarize, is that as Gagan mentioned, we cannot run away from the human resource issue. We can have the best devices, the best innovations, the best interventions, but if we don't have people to deliver them who are in sufficient numbers, who are adequately skilled and trained, then we just working in an environment where we are not delivering what we should be delivering. So we need to think about setting up and establishing HR norms, but continually call for investment in human resources, but also explore other approaches for meeting gaps in our settings, be it through task sharing and other approaches that might work in our settings. Thank you.
Excellent. Thank you so much for engaging with us and doing that on the fly. I really appreciate it. I wonder, actually, we're going to start a little bit on the panel question. And I wonder, David, I actually am going to come to you first on now, what do you think is the actual immediate next step for improving the quality of care? You mentioned going beyond infrastructure, having these different parties that are engaging with us, and the evidence around measurement. But what's the immediate next step that you think needs to happen to improve the care? Oh, David, you're still on mute. If you could unmute yourself.
Yes.
Great, thanks.
I think more importantly is that we have a lot of people who are partners who are working in different portfolios, be it nutrition, be it KMC and others, and a lot of great innovations and examples of implementing newborn care exists on the different partner platforms. And I think one of the things that implementers are struggling with, even as we encourage them to go beyond one at a time, is can we find a resource where all these interventions and case studies and learnings are archived in one place. And I think that's an important step in moving things forward. And NEST and UNICEF have co-designed and co-developed an implementation toolkit which has all these resources organized by the health system building blocks and with tools and resources that people might need. It's open access. You would argue it's a one-stop shop for implementers. But having said that, I think increasingly and more importantly, we just need to appreciate the use of data to inform our decision-making processes, and because that's the only way we will identify where gaps exist and what might be working or not working, and how best to implement to address the gaps that exist. Over.
Thank you so much, David. I'm actually going to come to Gagan with the same question about what is the immediate next step, and then we'll hear from Dr. Mwansambo and Dr. Imvalo as well.
Thanks, Catherine. I would say ensuring action on the ground, working closely with the countries, as simple as that. With 61 countries currently off track to meet the SDG target for neonatal mortality, and 80% of the neonatal deaths happening in the small and sick babies, there's no getting away from it. And WHO, UNICEF, and the global partners have identified the 5 critical steps for that. The first one was to set the target, which has been done through the ENAP. The second one was to identify the 10 steps for a generic model for district-level scale-up that has been agreed upon and which I presented in my second last slide today. The third is the implementation guidance. We have the NEST implementation guidance, but we still need the norms, and WHO and UNICEF are going to work on that, and next 6 to 9 months, you would be seeing that. Fourth is bringing the funding together. And a lot of these discussions are happening with the Gates Foundation, with USAID colleagues, with GFF also in the loop, and we expect that more alignment of the funding will happen. And lastly is tracking progress on the ground. So the revised ENAP tracking tool has a very detailed section on how to track progress on the ground. Second important thing is also to align this and integrate with other initiatives. And Kate is here. One of the important things which is right now happening is the revision of the EMOC framework. And if you see the previous N in the EMOC was just neonatal resuscitation. Neonatal resuscitation is the beginning, it's not the end. And that particular piece is being fully redefined to integrate the level 2 newborn care as actually the new N of the EMOC. That would be actually helpful in pushing the action on ground. And third is integrating it with the primary health care. And we have Dr. Balaji and Mickey from World Bank who have been pushing this agenda a lot. It's important to integrate it, what's happening at a primary level, and use the primary care facilities for the follow-up. Often there's a dichotomy of community or facility, but it's not community or facility, it's community and facility with follow-up back in the community. And we need to use the presence of the health workers, both for the referrals and for the follow-up. Lastly, with just 6 months and a year to go to midline of the SDGs, and also the fact that we are grappling still with the headwinds of COVID, it's time we need to move from global advocacy to country action, from focusing on planning to actual implementation, and from talking about scaling up small and sick newborn care to actually scaling it up. And we have seen from countries it is possible, so let's put all our efforts to push action on the ground. Thank you.
Excellent. So I'm going to ask Tisu the same question, who just presented the life data. So just as a reminder, we have the executive summaries there on the table for you, because this was particularly focused on a population that we don't have much research on or data on. And I wonder, Dr. Tisu, if you could share a little bit what you think about as the immediate next step and how the life results have influenced your thinking on that. He's also joining us remotely from, he's actually in the US right now, so he should be able to be on.
So hello, yes. So thank you for that question. I hope you can hear me.
We can.
I would put most of my recommendations in the context of the life study and a bit on personal experience. So we still have a lot of challenges with low birth weight babies. And I think one issue would be to work on the context of small for gestation age babies a bit. Low birth weights are a combination of preterm and small for gestation age. I think we appropriately in the clinical setting focus a lot on the preterm babies because they have trouble in the facility. But we also noted this group for this SGA babies having requirement for additional follow-up, additional identification, because what we also haven't presented in the study, but it's known medically, is that babies who are small for gestation age will have trouble as they grow. They'll at risk more of things like hypertension when they grow, metabolic disease, diabetes mellitus, and cardiovascular disease. So thinking out of the box, I think if we had approaches for small for gestation age babies, I think they're a bit more complicated because it actually starts from the mother maternally, so maternal services. Well, how can you prevent, a baby born with small, gestation age? Because this actually commences even pre-implantation in utero. And then another thing is the follow-up issue. That's pretty important, and I think it's come up in the live presentation, but also Dr. Gupta stated it. We have noted that the follow-up of these babies post-discharge, it's not well supported. We appropriately, maybe I would say appropriately because there was focus within the facility, but we are missing out in the community follow-up of how well these babies are developing and growing as they continue to grow and develop, and particularly I would say growth and development, because we also noted that these babies have developmental challenges. Sometimes we focus on gross development, but developmental challenges that are, developed neurologically can be subtle, but can be a challenge to development of, in the community. That productivity in the community, education-wise, and all those. So I think those are things to also focus on. Thank you.
Excellent, Tisu. Thank you so much. I actually am going to ask Dr. Mwansambo, the Principal Secretary of Malawi, to talk about it from a policy perspective, and then I'm going to come back to you, the audience, about what do you think is the next step? How do we actually engage in moving this work forward? We have these tools that have been shared. We've got a ways to go, though. So Dr. Mwansambo, if you're available to come online as well, we'd love to hear your perspective around the immediate next steps from your perspective as a country leader, whether that be from policy or implementation. I turn it over to you.
Well, unfortunately, I'm out in the field today. I was in northern Malawi, and I will let you maybe just play the video that I sent, and I'll be happy to take any questions.
Excellent. So we'll come back to that video in just a minute, but I think first let's turn to the audience then and hear about what do you all think is the next immediate step, and we'll cue up the video in just a second. So for the sick and small newborn care, any perspectives or implementation plans that you have underway about how you're going to move the care forward for your communities?
Hi, I'm Dhruv from India. It's not so much as how to move forward in our community, but just wanted to ask Dr. Gupta a question there. This is a lovely presentation and a wish across India that is implemented. In newborn care, have you also made provisions for surgical care for many of these newborns? Because a lot of them go into disability after that, and they will need disability care not just in the infancy period, but also probably throughout life. Which is something that governments and policymakers should be really thinking about. My disclaimer is that I'm a pediatric surgeon, so.
I appreciate the disclosure of potential conflict of interest there, but it's a great question. Gagan, would you like to answer?
Thanks, Dhruv. This is a very pertinent question. And if you look at the top 3 causes for the newborn mortality after prematurity, sepsis, and asphyxia, as you reduce the neonatal mortality rate, congenital malformations increase as a share. And I was last week in our European Central Asia region, and there 25% of the neonatal deaths are now because of congenital malformations. And no way you can manage them at a primary care facility without the backup of surgery. So what is being said is the level 3 care, which is at the medical college level, because for some things we need to do the regionalization of care, like early intervention, pediatric surgery, and these are at the level 3 care at the level of the medical college. And as we go forward and conquer the easy mortality because of sepsis, asphyxia, and prematurity, which is more difficult to conquer, congenital malformation will increasingly become an important thing. And the only share over last 20 years which has increased is the congenital malformation. So it's important that in the whole planning process, it should be taken as the regionalization of care at a medical college level and invest in the pediatric surgery part as well. And from our data from India, where we were recording congenital malformations, the neural tube defects were the most common malformation, and I think the preconceptional folic acid would be an important intervention to address that.
Excellent, thank you. Other reflections on what you've heard so far from either the LIFE study or Dr. Cathara's presentation from NEST 360 about the next immediate steps from your perspective? Okay, so I think we'll present Dr. Mwansambo's perspective from the leadership, country leadership. I'm just going to hit play. Is that right? Damien?
Greetings from Lilongwe, Malawi. Unfortunately, I couldn't be with you in person, but at least I can be with you virtually. I'm here to talk about newborn health in Malawi. Pleased to report that child health is a priority of the government of Malawi. And at present, we remain on track to achieving the child-related sustainable development goals. And talking about reductions in mortality, as a country in the last 10 years, we've managed to reduce our under 5 mortality rate from 112 to 63, the infant mortality rate from 66 to 42, and the neonatal mortality rate from 31 to 27. You can see that we haven't reduced the neonatal mortality rate as fast as the other parameters. One death is one too many. The newborn health is needed. So we need to prioritize our newborn agenda. Looking at the top cause of mortality in this age group for Malawi, the first is prematurity, followed by sepsis, and then the third is birth asphyxia. So investments in small and sick newborn care is needed so that we address these issues. Opportunities do exist because in Malawi about 90% 90% of our women deliver in a health facility. So this makes it possible for us to intervene. We need to have a policy framework that needs to address health system building blocks. And talking about the health system building blocks, starting with leadership and governance, as a country, we needed to define standards for all levels of neonatal care. And I'm pleased to report that we have developed protocols which are harmonized to address this issue. The second, of course, is human resources for health. Like most developing countries, we are short on human resources. And we also come from a history where there were no dedicated staff for these newborn units. But now we've defined the staffing norms for all neonatal units at all the 3 levels of care in Malawi, which is primary, secondary, and tertiary. We know that nurses, clinicians, quality improvement staff, data personnel, and even the biomedical engineers are all critical in newborn care. One challenge we've noticed in our system is the staff rotations. These actually have negative impact on our newborn care, and at times they've led to increased mortality in a period following these rotations. Coming on to the next block, which is health system, health service delivery and infrastructure. Before, we had old structures that did not have floor plans for neonatal care, and at present we are we are now in the process of designing floor plans for the district hospitals. In fact, some were working in tiny little corners that were meant for other purposes. And all our upcoming district hospitals have proper neonatal wards. Coming on to the next building block, which is equipment and supplies. These are a challenge because our central medical stores does not have or does not keep in stock all the equipment that we need for newborn care. But this is something that we're also working on. And finally, health financing. Our health system is heavily donor dependent, but I'm pleased to report that now we've come up with a health financing strategy, and in there we've prioritized domestic financing because this is now top of our agenda. And what's the reason for us to prioritize newborn care? If we look at our burden and disease, the recent burden and disease from Malawi, maternal and newborn health at top of that list. In fact, they've replaced HIV and AIDS as the major burden. It's very huge if you invest in maternal and newborn care. So I call on all of us present here today to make sure that we prioritize maternal and newborn health so that we get a huge return on investments. Thank you very much and enjoy the rest of the meeting.
Thank you so much, Dr. Mwansambo. I think it was very helpful to hear how Malawi has prioritized maternal and newborn health and focused on the next steps required. Dr. Mwansambo, if you can still hear us, I would love to hear your reflections about what you think the donor community needs to do in order to support this work, or what governments need to do from a financial perspective to support this work, or from your experience in Malawi. So if you can come off mute as well, we'd love to hear your reflections on that.
No, thank you very much. As I said, our system in Malawi is heavily donor dependent, and we have to thank most of the partners that we're working with to support newborn health. You just heard from David there about the nurse program. I mean, it's been very helpful helping us with equipment for the nursery. So my message to our partners is that you shouldn't get tired with the support. As we heard from Dr. Gupta, there's need to support countries, but at the same time, we also need to have an exit plan from the support that we're getting. But just to say that, as you saw in my presentation, unfortunately, I didn't present the slides. I mean, maternal and newborn health has replaced HIV and AIDS as top of our disease burden. So that's all the more reason to invest more in newborn health. Thank you.
Excellent. Thank you so much. I really appreciate that. Gagan, do you have any comments about thinking about funding and financing?
So I think the small and sick newborn care is very uniquely placed in the SDG agenda because it's one of the few things which speak to both survive and thrive. Because if you see 30 million babies every year need newborn care, and of which 1 million survive with some form of disability. So this is the only agenda which speaks very well to both the components of SDG, the survive component and the thrive component. And what is important is to have the momentum and funding to ensure that we are able to achieve this district level coverage. We still don't know the exact impact of COVID on financing for MNH. Probably the first set of data which we will get is from the tracking which we are doing for the ENAP, EPMM, where this is one of the things where we are also looking at the budgets and the budget allocation for MNH. But what's important is government leadership, government financing, and then having the partners' funding to be pooled and used most efficiently with a clear exit plan that would be helpful.
Excellent. Thank you so much. We're going to turn a little bit to the panel now. We actually were just interspersing a couple of the key questions. And actually, Gagan, you just touched on it about COVID. And obviously, this conference has been very focused on how COVID has implemented and impacted care. And I wonder, Tisu, could you talk a little bit about your experience in Malawi and how COVID impacted the care you were able to provide for newborns in your facility?
Yes, so just as it was globally, there were changes, major changes during the time of our work with COVID that impacted the way the work was done and also the way the care provided to the babies, actually all patients. You know, for instance, we all know with COVID, we had to have staffing rotations in hospitals. So medical personnel had to be on teams, okay? So that means less staff in the hospital at a time. So that actually can translate to gaps in the care provided in the maternity ward, in the labor ward. You know, we actually haven't published that yet, but we actually have noted that during the COVID time, there was a decrease in attending nurses or number of doctors for mother in the maternity ward. This is understandable, but it's just the way the COVID pandemic has been. We also noted that with COVID on the research part, we also had to modify our procedures. So what's important in putting that into context is that if there are programs, not just research, but if there are programs that are evaluating interventions, and we have this pandemic or have another pandemic, we just need to modify to make the best of what we can. You know, for instance, we had to think telephonic follow-ups at times. We actually had to book less people at a day so that there's less congestion in the follow-up clinic. The same can be done. So when we have pandemics, we can actually still continue our work, modify it, you know, to continue whatever goals we're trying to reach. There are some challenges that are going to be there, but you know, just trying to make the best out of what we can. But at the same time, the pandemic did affect both data collection and also the care provided or attending, the ability to attend as well as coordinate the patient.
Thanks so much. David, do you have reflections on how it affected your work with Nest 360 for when the COVID pandemic hit? Okay, sorry, we're having some technical issues. Well, I guess, Gagan, you and I had spoken about how COVID has impacted kind of the global perspective around maternal health. Do you want to talk about how it's affected the work you think about?
Right. So when the COVID hit all of us, we had an advantage of having the institutional memory from Ebola times, where we were having very clear evidence that there was a huge service disruption. So the message went very early in the field that be prepared to make sure that there is no service disruption. The earlier models which came were predominantly based on a very straitjacketed approach, which took into account that all services will be equally affected across all countries and all regions. But when, as UNICEF, we tried to look at the quantitative data from the HMIS and the program reports from 40 countries, we found things were very different. There were three things which emerged out. First was South Asia, East Asia, and Latin America were much more affected as compared to Sub-Saharan Africa. And that also was later on reflected in the unique immunization report, where the large number of children who were left out were basically from South Asia and from Latin America, and with a relative sparing of Sub-Saharan Africa. The second thing which came out was that not all services were affected equally. The services delivered from community and outreach platform like immunization and antenatal care, they were the early to be affected, but early to recover as well. While the services delivered through facility like the institutional delivery, C-section, small and sick newborn care, they got affected later, but also took a lot of time to recover. And third was, in the initial part of COVID, the physical barriers like lockdowns were, or the health workers moving out of the health post were the major barriers for accessing care. But as the pandemic became protracted, the financial barriers became more important as well. Now, another important thing which happened was a lot of separation of the mother and baby happened in context of the newborn care. Many countries with professional bodies initiated a policy where the early initiation of breastfeeding and separation of the mother and baby in COVID cases was, especially in the Eastern Asia. So this was one thing which was something which was very detrimental, and it took a lot of time to get corrected. But having said that, another challenge was the program managers, both in the government and the development partners, they were very much focused on COVID response, be it the response for the infection prevention control, the PPE, or for the COVID vaccination. So a lot of time of the program managers got diverted to this with not being able to focus much on the MNCH agenda. But having said that, COVID also got a lot of resources for health. And the buy-in to invest in the district hospitals after COVID has increased tremendously, especially oxygen, the wash, the infection prevention control, and the lab strengthening. And if we can build on this hook to invest in the small and sick newborn care, especially the oxygen piece, which is very critical, where a lot of investments have been made to the district hospital, would be very helpful as we move forward. Thank you.
Great, thanks. Are there other examples in the room of how COVID changed, impacted the services you were able to provide, and then how you've been able to resolve or think about how to improve care for the sick and small newborn? Country level examples or facility level based approaches? I think it kind of leads into this next question that our team had been thinking about is there've got to be examples for how we can think about sick and small newborn care. One of the things that Dr. Gagnon presented is really these 10 steps, but it requires immense interplay between finance, healthcare, larger education pieces. I mean, there's just a lot of work to do. And so are there examples in other maternal newborn health or health systems where we've been able to bring different parties to the table to actually address the needs of a disease or an impact? You just mentioned about COVID. Obviously, we had a lot of work focused on that and took a lot of requirement there. But are there other examples we could think about to improve the success of being able to address the sick and small newborn going forward? I wonder, David, if you have thoughts on that, if you're back online, or Dr. Mwansambo?
Thank you very much. I think key is coordination. We all need to work together to prioritize the newborn. The problem in our part of the world is that a number of partners will come and not work with the district, so not for the district implementation plans, or even the national plans. And as a result, you find that some of that support is uncoordinated. But as we mentioned earlier, we need to make sure that it's all coordinated with the end result of benefiting the newborn. So if you're talking about the finance, the financiers, the managers on one side, plus the clinicians, I think they need to be talking the same language, and our administrators need to appreciate what is happening in the nursery and so on and so forth. So once in a while, it does help to bring them to the nursery to see what the pediatricians and nurses are doing there than just asking for the finances all the time. Thank you.
Excellent. I think seeing is believing is what you're highlighting there. I finally wanted to ask Gagnon, one of the things we had talked about is how are we less afraid to fail? What are the advances we need to make to really make change in this space?
I think Catherine, you said it very aptly, I think probably it's the last concluding question. One of the things which we are guilty of as partners is we are very enthusiastic of doing pilots. But when it comes to scale up, we take a back seat. What's important is we need to walk the talk together with the government during the scale up phase, be it planning, be it implementation, be it monitoring. The funding may reduce during the scale up phase, but the engagement for planning to monitoring needs to be there. Second is sometimes when we advocate for an intervention and government wants a rapid scale up, they want to cover 100% districts, we tend to develop a cold feet and we take a back seat. I still remember when I was in India and we took the health minister to show the transport system for pregnant women. And the next question he said was, what will it take to scale up in the entire state? And I thought, how will we do it? But still I said, walking this journey together. And ultimately we did it. So you have to be not afraid of failing. The health systems were never perfect and will never be perfect. But we need to find the best of it. And instead of being pessimistic and cynical, we need to be more optimistic and see more opportunities than challenges. So sometimes we spend a lot of time in looking at the challenges, but as I said, health systems were never perfect and will never be perfect. So we need to take this bold step forward and move ahead. Thank you so much.
Excellent. So I'm going to turn it to you all. What questions do you have when you think about sick and small newborn care, how you move this work forward, or to answer this question about how are we more bold in the work that we do? We have roving mics around the floor, and I see Dr. Hirschhorn in the back.
I'm sorry, who? So thank you so much, Lisa Hirschhorn from the U.S. and Northwestern. So thank you all. This is really, I think, so inspiring. And as somebody who comes from HIV, hearing this sort of transition in Malawi is really, I think, both gives me hope, but also a challenge. I had two questions which are perhaps on sort of opposite ends of the extreme of healthcare, and one of which is, what's the role and how do we further capacitate the community health workers who are out in the community, both for the active detection, but also for the very important follow-up? And it's important. I had always been thinking of follow-up as like post, the immediate, but also in the long term. And then similarly, in some countries, what's the role of the private sector, and how can that be leveraged or capacitated to actually continue to move towards these goals? Thank you.
Excellent. So I'm going to actually have, I'm trying to think, Dr. Mwansambo, could you answer a little bit about the role of the private sector or the community health worker in Malawi?
Thank you very much for those questions. I'll start with the private sector. In fact, I just said in my presentation that we've developed a health financing strategy, and one activity in that strategy was engaging the various players in a dialogue. So we had a health financing dialogue last week where we even engaged the private sector to the discussion. And one thing that came out clear is that they felt that as a sector, we're not engaging them enough. I mean, we thought they knew what we needed, but they were surprised after the presentations that there were a lot of opportunities for them to come in. So I encourage colleagues in the room to make sure that when you go back to your countries, you engage the private sector in or even one-on-one or even group discussions to see where they can help us with the care of the newborn. Moving on to the community health worker. In fact, I'm saying I'm out in northern Malawi at present. We actually went to one remote part of the country to just appreciate the work of the community teams there. And indeed, they're doing some wonderful work. And most of the work that we do in hospital, if not linked to the community, then some of the kids will end up bouncing back. So we need to have a system where upon discharge from the units, we involve these community workers who follow up so that if any problems arise, they stop them much earlier, or they handle them much earlier before they turn into a serious condition as to need coming back to the units and bringing along the community infection. So we can use them effectively as community workers. We can work as a team. It's a continuum of care. So just as they refer the patients the other way, we can also do the same and get them involved in the care of the newborn. I mean, if you're talking about community KMC as well, I mean, they can help us also supervise some of the women with that. Thank you.
Excellent, Dr. Mwansambo. Thank you. Dr. Gathara, I think you had some reflections as well. Gagan, while we're waiting for, he's coming up or no? Okay, that's okay. Gagan, do you have any reflections on community health workers and private sector? And then I'm going to come to Vandana for the question.
Well, sure. Thanks. I'm Vandana Tripathi with the Momentum Safe Surgery Project. I really want to build on your question, actually. In your vision for how to do this, there are two planks that really resonated with us. Quality maternal health care links, and then this post-discharge follow-up, which is what you're talking about. That's also so crucial for cesarean section, for these surgical obstetric procedures that so many small and sick newborns have been delivered through. So I think a question is, how can we make sure that we're linking the maternal and the newborn follow-up when we're deploying these community health workers? They have so much to do. They're being asked to do more and more. And just curious to hear your recommendations, the collective for how to ensure this post-discharge follow-up happens, but in a packaged way that efficiently uses the resources. And now I return you your mic.
Thanks.
One of my professors said, whenever you have a mic, never leave it. Finish off what you have to say. So coming on the question of the community follow-up, I think there are two important opportunities, and most important is the home visit, starting right from the antenatal period, where the birth preparedness has to be a very strong component, where there's a clear plan where the woman will deliver, and in case of complications, where she will be referred. The second thing is the home visits of a healthy newborn, where you pick up danger signs and you refer. And the third part is when the baby is referred back from the hospital to the community, and the mother comes back with a C-section or with any obstetric complications back to community, how to do that. Again, it becomes home visits. But if you see, when we record, not all countries are recording the postnatal home visits for both mother and newborn together. Some are recording for mother, some are recording. There's a gap between the two of those indicators. So one thing which helps is sending an SMS reminder or phone call to the community worker when the patient is discharged, so that community worker is aware that in my village, a baby who is being discharged from a newborn care unit is coming. Second is, if the community worker can be trained on identifying the danger signs, identifying the key developmental milestones, the feeding needs, and especially infection prevention and control for these vulnerable babies. That would be something which would be very helpful. So I think what's important is to track the progress and then record the performance on follow-up. We initiated this follow-up system, but the performance on the follow-up, the first visit is very high, 60 to 70%, but then it starts dropping. And there should be a constant mechanism of engagement from the facility with the community worker in terms of the follow-up, either through the repeated SMS reminders or the phone calls, and probably a feedback from the community in terms of the quality and coverage of the follow-up visit. So these are multiple things probably that needs to be looked at. In relation to the private sector, in isolation, private sector providing these facilities is a bit costly. And also for many private sector, it's very less lucrative as compared to pediatric surgery, cardiac surgery, neurosurgery. So for them, the big money comes from those kind of things. But when you're contracting out the private sector, a lot of these things can be included. And contracting out private sector needs to be based on the fact that there will be a data sharing. Because many times you see the antibiotic overuse, the oxygen overuse, overdoing C-sections in the private sector. So any contracting out mechanism needs to be based on transparent data sharing.
Excellent. I see a question here, and then I'm going to go to the back, and then a third. And then, David, I'm going to try and come back to you again. So, Kate.
Hi, Kate Ramsey again from Scope Impact. Gagan, you just touched on a point that I wanted to make that I don't hear saying a lot, is that the people who use the services are also part of the system. And I can't think of a stronger advocate for this than a parent. And I haven't heard a lot about how families, parents, and communities can be engaged in advocacy, in quality improvement, but we also know both short-term and long-term care of sick children really falls into families' hands, and how do we make them more of a partner in this? And we know some of the strongest campaigns, as Lisa mentioned, HIV, have involved people who are affected, and I think it's something to consider, and I haven't heard yet. Maybe you're doing it, but I haven't heard it today. Yeah,
Excellent.
thanks.
No, great point. Actually, David, do you want to try and come in and respond to that? Because I think Nest 360 has involved families and patients. We'll try one more time.
Yeah, thanks. Can you hear me now?
Yes, we can. Thank you.
Okay, great. So yeah, as part of the family-centered care within some of the Nest facilities, there are efforts to try and use patient experiences or patient videos and videos from health workers as teaching tools for engagement with people who are in training on how best to address challenges and issues that parents might have, but also as a tool for advocacy. So some of the videos that have been developed and put out include playing in a panel where you have policymakers and ask them if they are really happy when, mothers are experiencing an environment where, for instance, they're sharing beds, there isn't, babies are sharing cots, there isn't enough space for everyone. And it gets people reflecting when they hear the mother's voice, the health worker's voice, saying how much constrained they are in delivering care to the mothers themselves. But it's also useful for the positive feedback, because it's not always bad news. They are, even in those constrained environments, you also hear very strong positive feedback to health workers in this environment. So I think they are unique, innovative ways of using those voices and getting them onto these platforms.
Excellent. So I'm going to come to the two questions in the back right table, and then I'll come to the one on the left.
Hi, thanks everyone. I'm Charlotte from the London School of Hygiene and Tropical Medicine, and I'm part of the IMPRESS project, which is a sister project to Nest 360 to understand whether improved management practices can impact on quality of neonatal care in Malawi. So my question is about human resources, and Dr. Gupta, you talked about a multi-pronged approach for human resources in hospitals, and Dr. Mwansamba, you also mentioned about staffing norms and rotations. I was interested if there's any best practice examples you've come across in your extensive experience of how we can improve human resources for the neonatal unit. Thanks.
Gagan, go ahead, and then we'll come to the... Sure.
Sorry.
Thank you, Arlette again, from Mozambique. So I was wondering also if there is a new experience, because what we see for the babies who are born with low birth at the community level, and the death is not reported at national level. Yeah. So usually these babies go home and they die in the community, and we're not aware of that because the way the system is set up, you can collect that data. Is there any way experience that can lead us to understand how these babies die, and how can we get the information about their death at the community level? Because we only have information at the district and provincial level. Thank you.
Great. Gagan, I'm going to go to you, and then Tisu, I'm going to come to you.
Thanks. Thank you so much. On the issue of human resource, as I said, there's no single solution. And I can speak for the India example, which is very strong for the human resources. So first thing is, when they were setting the human resources, there was a dilemma whether we do manage with the existing staff or we do additional positions for newborn care. Now, existing staff is already overworked, and if you deploy 2 people from here, 3 from there, you are depriving of the primary facility of the staff, and then what you are putting is also not enough. So it's always good to have additional staff for the newborn care units with norms defined. Once you have done that, you can go for a contractual appointment or a regular appointment depending on how the system permits. After that, to attract the resources, there needs to be 5 or 6 things. One is, often when people need the job, we don't provide them the job because our vacancies comes twice a year or once a year, or sometimes there's a backlog for 2 years or 3 years. It's important to initiate things like walk-in interviews on every fixed Wednesday or Monday of a week, every first Monday or first Wednesday of a month. where you can have people walking in with their documents, and if the jobs are available, we can give them. Many times the recruitment is centralized at national level when a lot of this can be decentralized to district level. So decentralization and walk-in is the first step. Second is in difficult area allowances, giving them incentives in terms of educational allowance for children, the transport allowances. We also went for a policy called You Quote, We Pay, where in most difficult areas, the pediatricians and nurses were asked to quote what they would like to work in these areas, and they were given those kind of things. The rural service bond, then task shifting, Dr. Rajni spoke about it. So there are multiple things which you will need to look at, and nursing aides instead of staff nurses to help and reduce the load of nurses, that can be one thing. And in relation to the community thing, what's more important is you have a system by which you track these newborns after discharge. And one of the things is the phone call back to the community worker. And the whole community worker piece becomes very important because of this whole thing. And then you need to invest in strengthening your vital registration system, which ultimately is the goal solution for that. So.
I turn to you while we're having a microphone run to the back left corner. And and here as well. And just to comment, I think about your comment about the community birth situation. There are some research studies that have figured out how to connect on that early identification and notification around birth. We used it in Zambia, and it was very effective to try and use the community to help report that birth and then be able to do the follow-up, because not everybody's going to deliver in the health system. And so I think we have to recognize that and value that life and make sure that we're connecting those families back into the health system where it's most appropriate. So Tisu first, and then I'm going to come to you in the back.
So yes, the issues of human resource, as appropriately said, and probably well known, are pretty complicated and can be quite challenging, because even prior to adding other roles, human resource is very challenging, for instance, my setting, the low-income setting. But I think one first approach, one thing could be trying to multitask the existing cadres with additional roles within the facility, as much as possible, what may feasibly be added to the roles on that. You may also we should also incorporate additional cadres in the community. In our setting, we have health surveillance assistants, but whatever exists in that setting as community health workers, to have them also involved in this exercise, and to also, as we also probably said initially, inform them or educate them on the flags to use. So what flags do we have of a baby not doing well in the community because been discharged, who needs to be referred early, or who was referred, things seem to have been corrected, but things on return are still challenging, because that's where these more vulnerable babies spend most of their time. They can come to the facility, we can do what support we can do for 3 days or 7 days, but once they go to the community, that needs to be continued, and that also needs to be linked with the facilities as well. So there needs to be a linkage between the facilities and the communities, on how to monitor the babies and how to support them in the community. It is quite true that deaths in communities are pretty common, and I think one way to bring that up to the attention of policymakers and how to intervene is also setting up monitoring systems in the community. So the same community workers, and it depends on the countries. Some countries have death registries or community death reporting. For Malawi, that is still being set up, but for other countries, it's probably set up already. But we have actually noted we've got the National Registry Bureau, which is just started that in Malawi. It's a bit delayed, but that also gives some amount of data or information on what are the points in the community. Because most of the data that we have are facility-based. But in the community, there are also windows that we need the data first to know if babies die, what are the causes of death, what's the time frame, so that if there's also follow-up, we know what the windows are. Is it the first 2 weeks? Is it the first month? And what are the patterns of death? And we can also know when to intervene. So the community data collection and monitoring, and also coordination with the facility in various programs and ministries or departments and health is quite important. Thank you.
Excellent. And a question here in the back.
Yes, thank you very much. Dr. Chuanuka Henriksson from the Swedish International Development Corporation based in Lusaka. My question is about the importance of equipment. We all know that that is important for the sick and small newborn, but also equally important is the use and correct use of this equipment, which means that we need to have skilled health workers, not just numbers, but actually skilled health workers to use the equipment correctly. So my question is, can you reflect from your experience, and this can go to any of the panel members, on how to get that mix right so that we don't have scenarios like in Zambia where you have brand new equipment sitting in facilities that has never been used, or equipment that has a very small fault that is not used, or equipment that has no spare parts available in the country. So just a reflection on how we can get the right equipment with the right skill, but also keep it working. Thank you.
Excellent. I'm actually going to have Gagan, you respond. And David, I'm going to ask you to type in the chat since we're having some technical issues to make sure, because I think that's exactly what Nest 360 is trying to do, is this marriage between equipment and the skill set to move forward. So I'll read whatever David types, but Gagan, if you have questions.
So I think, as you rightly said, equipment is a big Achilles heel, and getting and procuring the equipments or for a partner to supply equipment is probably the easiest thing. But to make them functional and to keep them functional is the biggest challenge. So first thing is, ideally, if your pre-service training is good, you will not struggle with this, with people not knowing how to operate these equipments. Now, given the fact this is a very new area relatively, the pre-service courses do not train the people well. Often you have to hire nurses who have never handled small and sick newborn and then teach them on the job. So what is important is the whole planning of equipment procurement needs to have a clear operationalization plan. And having these small videos or YouTube videos, how to quick fix the small errors in these kind of instruments like pulse oximeter or radiant warmer always helps. And even Nest 360 plus many of the other organizations who are working in this field are looking at it, and there are very good material, teaching material, which is available and that needs to be used. In regards to the fact that if the equipments break down about the repair, one thing which helps is to have 20% extra buffer stock, because if the downtime to repair is high, you can use the buffer stock to replace, and then a biomedical engineer or a biomedical technician can repair it. The third thing is, at the facility, even if you don't have an engineer, which is not often warranted, a technician can be trained to do the small fixes. And then the biomedical engineer can be at a regional level covering 7 or 8 districts. And then on a fixed day, he can be visiting the district to handle and repair these equipments. But the point is very valid that buying equipment without a plan to operationalize and without a plan to maintain is a disaster.
I would just also add from our experience at Ariadne across a variety of topical areas, we've used a lot of peer counseling, peer-to-peer education to focus on skills development and coaching models, and I think they can be very effective. So it's not about having everybody at the highest skill right away. It's about having a plan about how you use that supportive supervision or a coaching framework, and they are slightly different, to make sure that the clinicians who are providing care have the right skill sets. We use this work in childbirth in previous settings and have found it quite effective, and I think it's a model. I know that Nest 360 is working quite a bit on it. So I want to just share what David wrote in the chat. So he said, the Nest 360 approach includes joint training of clinicians and biomedical engineers together using hands-on training to focus on the use of the device, the troubleshooting, and it also includes the medical device support through supply chain for the pieces itself, as well as the spare parts. And I think that's always a connection that has to be made, so I deeply appreciate the question. I think I missed some people. I think there was one here. And please feel free to let me know if there's others. Just pop your hand up and I'll keep scanning the room. Yes, to you.
Thank you. Pooja Shripad from Population Council, and this is a great panel, and it was really nice to hear kind of the full, from all the country examples. I wanted to, well actually this was a good sort of transition. I wanted to think about 2 particular groups that are kind of important in terms of perspective and building off of Kate's point earlier. And I'm talking about this based on some of the work we've been doing under breakthrough research, focusing on behavioral, targeted behavioral approaches, working with providers and around care of, supporting parents to be involved in care of small and sick newborns, but children up to 2 years. And I think one of the groups is definitely providers. So thinking about that group, and you started speaking about coaching, and so I'd love to hear a little bit more about those models, and if some of those models, we found that, for example, thinking about mental health and support for providers working in the setting, and also mental health and support for parents going through this very traumatic period, right, with their child in the hospital. So I was curious, sort of, if there's any examples from your countries that looked at that. And the other piece was to think about the role of the father. So in a lot of these settings, it's typically the mother and part of space, and you know, we know the logistical issues, and so what we ended up doing in sort of developing the interventions were, of course, engaging parents as part of that discussion, and fathers really, you know, wanting to participate in that as well. And so I was curious, and you know, we had the COVID challenge. We managed to do some work around this, sure. But I was just curious to sort of see if, I think that's an area we need to continue to develop collectively and understand how to bring those sort of behavioral aspects to the forefront, because we understand the logistics and the supply and the enabling environment, but to really get it to that next level, it seems like an area that we may want to focus on.
I think it's a great question. Just to reflect on the life experience, and I'll share that, and then I'm going to turn it to Tisu specifically about that. We actually had a lot of qualitative research and questions with families, grandmothers of low birth weight infants, a lot about what they felt comfortable feeding the child, who was the decision makers in the home around the feeding in particular. We have a lot of quantitative data about separation of moms and babies, when that happens early in the time around the NICU, but then also later, and who's making decisions again around that feeding once children are in the community. And it's that critical piece, and I think you both have advocated for it really well, about this engagement with families. I think there are some examples we've seen from March of Dimes and others about parent support groups and advocacy to really have them engage in their own care, but also more broadly. As you said, I think they can be some of the strongest advocates for us. Tisu, do you want to add anything about the experience from life or the qualitative work from your perspective?
Yes, so broadly stating it, it's maybe just expanding what you're saying is that when we have these interventions, we also need to put in the context of that setting. So in the setting of the sites of the life study, we actually found that influence on the decision on the care of the baby, there are gaps. It's not just what we told them in facility. There's actually as I said, in facility they spend a few days, like 3 days or 5 days, maybe longer if the baby is pretty term. But from our qualitative interviews, when we started inquiring on what influences or decision making on the care of the baby and feeding, actually about a third came from an extended family. So that's the aunts, that's the uncles, that's sisters, so if the sister is grown up enough. And then, also when it comes to caring for the baby, it's not just the mother, it's also the same extended family in a third of the cases. So this messaging in the community, we should not just focus it on the context of the mother in the hospital. The father, of course, also needs to be involved, but also whoever is also influential in the community, the extended family, or which other influential team members are there in the community. Because if we just focus on the facility and say, this is how you take care of a low birth baby, this is how you feed a vulnerable baby, these are the danger signals, we're actually missing out in this context at least a third of audience that needs the message to also be received. So that's also important to put it in the context of who has the influence of decision making on the care of these babies at home, because we actually sometimes miss the audience getting the message across to the right team. Thank you.
Excellent. So I think we're going to wrap up to give everybody time to have a little bit of networking and connect in the room. I know we're standing between you and lunch, so that's it can be a potential barrier. But I just wanted to say a deep thanks to you all for attending. And I'm going to turn it to Gagan. You want to say one more thing, and then if our colleagues on Zoom have something else to say.
Right. No, I just wanted to thank all of you, and especially also to Daniel and Elizabeth, to Eliza and Daniel, because they've been working very quietly for all the preparation, and to Linda and to Catherine, because without all your preparatory efforts, this session could not have been so well. And I also wanted to acknowledge the presence of Dr. Balaji, who is our health systems lead in the rear, and Paula, who is from our Nigeria Health Systems team, who have been here for this session, and to all of you for being here, the last few champions standing in the room still. Thank you.
Thanks so much. So really appreciate your time. Please feel free to ask us questions about the life study, how we can think about moving this work forward for the 20 million or more small and sick newborns. And just again, my deepest thanks to our panelists and engaging with the conversation today. Have a great session.